Muy buenas tardes a todos. Muchas gracias por estar acá. Como equipo Lilly estamos muy contentos de tenerlos a ustedes el día de hoy acá en este gran congreso de reumatología y de tener como invitado a alguien tan especial, tan conocido y tan conocedor del tema como es el doctor Xenofon Baraliakos. El doctor es un experto en espondiloartropatías, reumatólogo con experticia clínica y en ensayos también clínicos, y nos va a hablar de espondiloartropatías y Taltz, un abordaje desde el consultorio. Es un placer tenerlos y gracias, doctor. Thank you.
English.
This is the mouse. You can use the mouse with the screen. This is your return screen, and this is your screen, and this is the pad. You can go ahead, left, right, everything. Okay.
All right. So thank you for the invitation to speak in this Congress and in this symposium. I know that there is translation, so I will try to speak in a way that also the translators will be able to express exactly what I want to show you. Because for the next, let's say, 30 to 40 minutes, I will try to discuss exactly that topic that is on the screen. This means, first of all, how to identify, and by that I mean how to diagnose axial spondyloarthritis. And then we will speak about treatment. One thing we need to take into account is that we do not have a diagnostic criterion for spondyloarthritis. So if I ask everyone how you diagnose spondyloarthritis, you may have completely different ideas. I will try to show you my opinion on that. Spondyloarthritis, in that sense, would also mean not only axial but also peripheral spondyloarthritis, and also the axial psoriatic arthritis in part. And this has obviously implications of how we treat this disease. Now, remember, I will speak about axial and about peripheral spondyloarthritis only in this case. Peripheral spondyloarthritis includes psoriatic arthritis. And as I mentioned, we do not have diagnostic criteria for SPA, for spondyloarthritis. For the axial component, we may use the criteria that I show you here, but remember, you may make mistakes if you apply them one by one to each patient, because here there is a lot of differential diagnosis that may lead to wrong diagnosis. For example, you may have sacroiliitis that has nothing to do with spondyloarthritis in a HLA-B27 individual, positive individual, with back pain. This can happen, but this is not SPA. Again, I will try to show you the concept in a second. In any case, what we know for diagnostic purposes is that we have the different stages of the disease that go from the earlier to the later stage, from the non-radiographic to the radiographic stage. On the other hand, we also know that the non-radiographic stage is not lesser in risk. They have the same symptoms as the radiographic patients. How would we do it in daily practice is a very easy example to show you. You, of course, are rheumatologists, and of course, you see the patient, and unfortunately, you see the patients in a relatively later stage after this back pain symptoms have started, and therefore, also in order to utilize the imaging, the MRIs of displaying, of showing back pain, you may get patients from the orthopedics, you may get patients from the general practitioners who have those spinal MRIs that show nothing. So again, I'm trying to show you how to diagnose, not so much how to classify. And diagnosis may also be done in a situation like this, where the patient, in a young male person, had low back pain, but the MRI of the spine was completely normal. In these cases, I do suggest very much that you always try to ask for additional imaging. We have it in our hospital in this way set up that in patients with low back pain in a young age and normal spinal MRIs, we always also do an MRI of the sacroiliac joint. The pointer doesn't show that very well, where the sacroiliac joints may display the bone marrow edema, on the, here on the left sacroiliac joint. So altogether, my recommendation, my advice to you is really try to apply imaging wisely, listen to the patient for the back pain, and also maybe add some sequences when it comes to the diagnostic approach. Again, this is a very typical example. The patient comes to the hospital with back pain, spinal MRI is normal, and nobody cares anymore. Please try to convince your radiologist to do also additional imaging. One other thing that I would like to remind you for diagnosis is that, as you see on the slide and the title, that you should not go into the mistake that non-radiographic axial spondyloarthritis is milder than radiographic. You see here a typical patient with, on the left side, the STIR sequence, the STIR MRI, with a lot of inflammation. If you look at the X-ray of that same patient, that doesn't show anything pathologic. However, the T1 MRI of that patient on the right side shows severe erosions and also fat metaplasia. Again, this patient is non-radiographic, but has a severe disease. So for diagnostic purposes, it is important that we do not care about non-radiographic or radiographic. We see that the patients, even in the so-called non-radiographic form, are very much affected by the disease and also have the same symptoms. They may also have erosions and fat accumulation. Now, these are data from studies that have been done either locally in one hospital. This is the study by Uta Kiltz that you see on the left side of the bars, or in a worldwide study, the RAPID trial, on the right side of the bars. And both locally and in the worldwide population, what we found was that ankylosing spondylitis, the radiographic part, and non-radiographic axial spondyloarthritis had the same amount, the same proportion of patients being affected by peripheral arthritis, uveitis, enthesitis, psoriasis, and inflammatory bowel disease. Again, this very much shows that non-radiographic and radiographic stages are good for classification, but our diagnosis refers to the disease that is called spondyloarthritis. And it doesn't matter if you're working in Medellin, if you're working in Bogota, or if you're working in Berlin. The patients you will see are the same. Non-radiographic and radiographic, they suffer the same. The same is about the age, so there is no difference in the age of patients at diagnosis between non-radiographic and radiographic spondyloarthritis. The same is also for the HLA-B27. So please do not do the mistake to say, well, somebody is non-radiographic, I can wait, I will not treat them. It is good to treat these patients early enough. One thing that we need to take into account when it comes to diagnosis, and this is tricky, is that CRP, as the systemic inflammatory marker, is positive, but not in every patient. I have seen many situations where CRP has been negative, and therefore even rheumatologists have not given the diagnosis to the patients. However, a negative CRP does not exclude spondyloarthritis. If you are CRP positive, you see that here you are more at risk to develop radiographic stages. But also the non-radiographics may have, thank you. But also in the non-radiographic stages, or in the non-radiographic stages, you may have more patients with normal CRP. So it is, this is all introduction to one slide that I will show you later. However, please keep in mind, it is tricky with this diagnosis, and it becomes lesser tricky, it becomes clearer if we pay attention to all this that I've told you. So, how can we indeed diagnose? These data that I show you here are older. They've been published very long ago, but they are still valid. At that time, we calculated the so-called likelihood ratio, the probability that if you're positive in the one or the other symptom, the probability to become AS patient later. The higher the likelihood ratio, the higher the probability to have the diagnosis. And you see that, unfortunately, the reason why patients come to us, which is inflammatory back pain, you remember I discussed this in the beginning, has a very low positive likelihood ratio. So inflammatory back pain is the initiating symptom, but it is not very much related to the diagnosis. It is a combination of symptoms we need to take into account. And how do you make a diagnosis out of this table? You make a diagnosis by, if you want to calculate, by taking all these symptoms and multiplying these numbers. Now I'm going from science to clinic. I will therefore try to show you what I believe is happening in daily practice. This is the key slide for the introduction. We have patients who are young. They are below 40 or 45 years. We have patients who have chronic back pain, preferably inflammatory. And what we have, maybe in this situation, a patient with a positive MRI. Would you believe that this patient has spondyloarthritis? Independent of what you would vote for now, I would like to show you a different situation, a different scenario, where the same patient has no MRI positivity. The MRI is normal, but has a B27 positivity. Is that patient more prone to develop ankylosing spondylitis later? You may have the other scenario, where the same patient is negative on MRI, negative on B27, but has high CRP. And you've clarified that the CRP is not bacterial. Yeah, it is of unknown other reason. So back pain, young age, positive CRP. Is that situation more close to the diagnosis, yes or no? And you may also have the situation that the same patient is negative on MRI, negative on B27, negative on CRP, but comes in and has psoriasis. Or in addition has positive family history. The father has ankylosing spondylitis. And also has enthesitis. Which of those four patients is more probable to have spondyloarthritis? You may play the different scenario in your mind. But if I would go back and I would show you the likelihood ratios and the calculation that we do in our mind, you will see that the positive likelihood ratio, this is in green, is almost 20 times higher in the fourth scenario. And that patient needs treatment. The first one may also need treatment, but you need to be very, very clear about back pain and MRI positivity only. In the bottom, you see the negative likelihood ratio, so you exclude the diagnosis. And you see that, in fact, there is no big difference. So if the MRI is negative, that doesn't mean we exclude diagnosis of spondyloarthritis. So this is the way diagnosis is different from classification. We very much need our expertise, and therefore we need to understand what the concept of spondyloarthritis is. Now I have also this scenario, where the patient is young, but has no inflammatory, only chronic back pain. No MRI, no B27, no CRP, but you have a young person in your office that has psoriasis, has a positive family history, has enthesitis, and also has one swollen joint, let's say knee. What is the probability of this patient to have spondyloarthritis? Even peripheral psoriatic arthritis. It is, in fact, even higher. Yeah. So altogether, what I want to draw your attention at is that the diagnosis is difficult and easy, both at the same time. We should certainly pay a lot of attention on imaging. We should certainly pay a lot of attention on the genetic predisposition and CRP, but the most important thing is the clinics. And who is doing the diagnosis? It's us, it's the rheumatologists. And after consideration of all the symptoms. And again, the fourth and the fifth patient need treatment the same as the first and the second. Now, about treatment. I will try to give you some information about the newest data. It was also said in the beginning. I will also speak about exekizumab and also the Taltz data in the treatment of axial spondyloarthritis. But in fact, I would like to show you the entire spectrum of how we treat. And we will discuss about the entire algorithm of treatment later in another session in the afternoon. Now, keep in mind what I told you about the concept of spondyloarthritis, about the diagnosis. The patient has symptoms. They have pain. Yeah, they have swollen joints. They may have psoriasis, whatever. We know that there is an inflammatory cascade. There is something that is maintaining the inflammation in the body. If you do not have spondyloarthritis yourself, I don't know how many may have that disease in the audience, but you're B27 positive, by the way, you may be more prone to maintain bone marrow edema. This is clear. However, you do not develop SPA. These patients that I show you here in a cartoon, they develop a chronic inflammatory disease. And this chronic inflammatory disease is due to the secretion of cytokines. IL-23, IL-17, TNF. We also know that IL-6 plays a role, although we cannot treat IL-6 with IL-6 inhibitors and so on. And you see that IL-17, and that's my focus now, IL-17 is in the middle. We know that IL-23 does not work. IL-23 inhibition does not work as a treatment target, but IL-17 inhibition is the starting point of our treatment. This has taken place, or this has been incorporated in the treatment recommendations of our patients. Here for psoriatic arthritis, this is the newest recommendations of GRAPPA, where IL-23, IL-17, and TNF blockers have been included as parts of the treatment options. And here you see also the ASA's EULAR recommendation for axial spondyloarthritis, which unfortunately I cannot show you very well on the screen, but I will refer to also later, where we do not anymore, in the update, we do not anymore rely only on TNF blockers, but have included IL-17 inhibitors as well in that, in this algorithm. Here you see that on the right part of the slide. So in the left is the 2016 recommendations, in the right it is the 2022 recommendations. We have elevated the status of IL-17 inhibitors and JAK inhibitors as a biologic DMARD treatment in spondyloarthritis, saying also that we very much care about the phenotype of the patient in axial disease. In a patient, for example, where we have uveitis or active IBD, we would prefer, not exclude the others, but we would prefer the TNF blocker, monoclonal antibody. In a case with psoriasis or peripheral disease, additionally, we would prefer an IL-17 inhibitor. Now, what does that mean for the treatment? And I'm using the exekizumab data. I will show you some results It's not about showing you the numbers. It's about showing you the understanding that we have for this disease. And the understanding that we have is based on how the studies have been developed and designed. So the ixekizumab program has included the COAST V and the COAST W studies. These are ankylosing spondylitis data, with or without pre-treatment with a TNF blocker. The COAST X, that is for the non-radiographic, and the COAST Y, that is for the extension periods. All of them, nevertheless, were having more or less had the same design. The patients got the treatment or placebo, and thereafter went on with the active drug. So you see here the designs. On the left side, on the COAST V, the important thing to remember also is that we have an adalimumab arm that was running in parallel. This means we do not have a direct comparison, but an active comparator, as we call it, for the gold standard of a TNF blocker, which would be adalimumab in that case, or at least a representative of a TNF blockade. Now, what did we do? And if you ask me again, what does everything that I told you so far, how does that translate in this slide? It shows very nicely that if you choose your patient properly, a vast majority or a big number of patients will indeed respond to the drugs that we have. Stopping the inflammation early enough, IL-17 inhibition, means no further inflammation, means actually a good response. Here we took ASAS40 as a good response. You don't need to know exactly what that means. It doesn't matter. It is very clearly, this is the clinical situation we want to have. And every second patient, already after a couple of weeks, you see here 3 to 4 months, was in fact improved. And this maintained over time. We also have low disease activity status, which in fact shows exactly the same results, which again means that if I have a patient, and that's the question you will get, if I have a patient and he or she has the diagnosis that I mentioned, what would be my expectation? That this patient will come to the office 3 months later and will be free of symptoms. The expectation is 50%. And this is actually pretty high, every second patient. Other outcomes, without wanting to go too far, also because of the time, but also because I believe it is a pretty clear pattern. All the numbers show to the same direction. Also, BASTAI has improved significantly, what we are measuring in daily practice. And also other outcomes which may be more convincing, and this is what you see here. MRI and CRP have, in fact, almost disappeared the objective inflammation. So in the MRI, you see on the left side, there is improvement in the actively treated patients and almost no improvement or even worsening in placebo. So what we do is correct, is true. We take away the inflammation. Independent, again, if the patient has or does not have the MRI positivity before. Yeah? CRP on the right side, the same thing. So we do not only improve the pain, we improve the inflammatory activity. That is a very clear message I can give here. What happens to the non-radiographics? And this may be a little bit tricky now, because you see that the numbers are a little bit lower. To me, it is important when I show the data or such data to understand what I'm showing. And I would like you to know that the numbers you see are due to the different designs of the studies. So not only in ixekizumab, but if you look at the secukinumab data, if you look at the adalimumab data, if you look at the golimumab data, if you look at the certolizumab data, all data that we see in patients with non-radiographic axial spondyloarthritis are lower. The responses are lower as compared to the radiographic axial spondyloarthritis, ankylosing spondylitis patients. Why is that? This is due to the fact that the study designs are different. Here, in the non-radiographic studies, we always have the interaction of the authorities, such as the FDA, that tell us that we need to have, and this is, I believe, not so ethical, but in any case, we need to have a 1-year placebo control phase. So that you put the patient in a 1-year placebo. And if the patient doesn't tolerate it, he or she has to go off the treatment, and therefore you, in fact, present the more conservative analysis where you have lost many patients, and that's why the numbers are lower. We do know the numbers of the responders, and they are indeed very, very similar to what we know from the radiographic patients. Similar, by the way, pattern for the low disease activity status. So don't be afraid or don't be worried that in all the studies that we have, the non-radiographic patients show lower response rates. Here, the BASTA situation, a similar thing. So everybody would improve. The results may be not so good as in the radiographic population, but this is due to the study design. And also the MRIs in the same pattern. So again, without wanting to go into all the details and the numbers, I think it's good for you to have at least got a flair of how these studies have worked. Now, this is fine, this is easy. Yeah, you have a patient who you've diagnosed the patient, you treat the patient, and every second patient will be doing well. The question is, how do you go on in patients who do not do well? You know, you give the biologic and the patient doesn't respond. What do you do? Well, in the old recommendations in 2016, we've said that we've started with the TNF blocker and then we would switch to an IL-17 inhibitor or to another TNF blocker. In the 2022 recommendations, again, you remember we've elevated IL-17 inhibition and JAK inhibition on the same level as TNF blockers, and again, here we have no alternative. We need to switch from the one to the other mode of action. Now, there are not many studies that have addressed the question on whether when you start with adalimumab, let's say, and the patient does not work, if you switch to another TNF blocker or if you switch to an IL-17 inhibitor, what happens? This is the only data that we have from the COAST studies with ixekizumab, and the brown bar is the important one. What we have seen is that if the patient does not respond to adalimumab, switching to ixekizumab pretty fast brings 25% of good responders. So altogether, my recommendation is if you start with the one mode of action and the patient does not respond, switch to another mode of action in order to capture all the inflammatory cytokines that may be there and play a role. And of course, the other thing is what you do if the patient is doing well. Do you continue? Or do you stop? Or would you rather decrease the dose? I will also discuss this topic later in the afternoon in the recommendation session, but I would like to show you at least one piece of studies, again with ixekizumab here. It is a busy slide. In fact, what you need to pay attention is the lower part, the lines. And the lines are showing that if you are in remission and you stop the treatment, in gray color, then the patients will relapse. If you are in remission and your patient asks what to do, then it doesn't matter if you continue as you did before or if you decrease the dose. The patients keep on the same good level. So, in fact, spacing the injections may be one solution for long-term treatment when it comes to decisions with our biologics. One other thing that we also need to pay attention at is the radiographic progression. And I mentioned in the beginning, we know, and I'm convinced, that independent of which biologic you would give, TNF blocker or IL-17 inhibitor, you stop radiographic progression. However, you need to do it in a long period of time, or at least 2 or maybe even 4 years. The bars that you see here are the bars of progression under ixekizumab in ankylosing spondylitis, and you see a 0.3. What does that mean? It means that the progression was almost 0. So after 2 years, no progression. The patients stay as they were. There is no radiographic progression. The question is, why is that happening? I will try to make it relatively short, because you can speak about radiographic progression for an hour, but I would like to go back in time and show you, before the studies with IL-17 inhibitors came into the market, what we knew from the lab. These are data that have been published in the meantime. 2017 was the full publication. Data from the Netherlands, where the colleagues took the transgenic rat models for spondyloarthritis. They infused, or they induced the disease, you see it in the upper part, and the rats got spondyloarthritis. This is all the red lines, the red dots. You see on the CT, in fact, on the right side, that these rats also develop new bone formation, peri-osseal new bone formation. When they treated the rats, so the one group did not get the treatment, the other group did get the treatment. In the rats that they were treated, in the lower panel, new bone formation did not happen. So obviously, there is some hint that we do also a little bit of a disease modification. We stop this new bone formation overall. What happens in the humans, in the patients? We know that we have biomarkers that predict radiographic progression in ankylosing spondylitis. The most important biomarker is the one that you see here. It's called DKOPF1, DKK1. And what does this biomarker do? The lower it is, the more new bone you get, the more syndesmophytes you get. The higher it is, the more protected you are. If we look at the data of IL-17 inhibition in patients with spondyloarthritis, including psoriatic arthritis, by the way, here, you see that the longer you treat with the IL-17 inhibitors, from first month to month 3 to month 6, you get more DKOPF in your body. So in fact, we protect the patients from developing new bone formation. There is also other biomarkers such as sclerostin. You see that on the right panel. Sclerostin is also, if it is high, it's protective, and also sclerostin levels increase. So altogether, there seems to be also a biomarker explanation why there is no radiographic progression in these patients treated with ixekizumab priorly. In order to finish, I've brought in two actually pretty simple cases. And I was asked to bring some cases also from the educational purpose of the symposium, but also because I would just like to show you how we work. I think, in a meeting with rheumatologists, you will be able to follow everything pretty easily, but please keep in mind that this is what you may also see next week at the office. And therefore, I will not really spend a lot of time to these cases, but just remind you what may happen. Here you have a female 41-year-old patient with typical pain, inflammatory back pain, especially at night, B27 positive, non-radiographic axSpA, also has comorbidities such as high cholesterol, hypertension, and also is slightly overweight, and also has uveitis, repeated uveitis. CRP is slightly increased, it fluctuates also. Now, that patient came to the office in July 2020. She had got diclofenac, had good response. You see that the BASTA was around 4. You remember BASTA of 4 means the disease activity I need to start with a biologic DMARD. She had fatigue, had stomach pain because of the NSAIDs, had fatigue, had lesser activities of daily life, was slightly depressive, then it was changed, the non-steroidal was changed to a COX inhibitor, COX-2 inhibitor, with a good response. However, she developed further issues with the non-steroidal. This is something that is happening pretty fast. And therefore, she was started with ixekizumab. We had ixekizumab at that time pretty new. And that's the important thing now. Of course, we expected that she would respond well. But what's happened was that not only the BASTA went down, but also the pain and the fatigue improved. And the organ situations, especially the renal function normalized. My point here is not that the drug works. I've shown you the data, that's easy. The important thing here to pay attention is that the patients would come and we would have to change the treatment if they would feel fatigue, if they would not be able to do the daily life activities, if they would be unsatisfied because they still sleep the whole day. And I'm pretty sure you've all seen fatigue patients, pretty many. We have a large department where we also try to do something more for pain and fatigue in these patients, and we know that if you have a fast and good response to these patients with a biologic, and you see that this in fact happened within 4 weeks as well. Second case, again also relatively easy, but just in order to show you my experience with that. An older case of a patient who had the diagnosis many years ago. Main complaints were typical inflammatory back pain, also fatigue, enthesopathy, orthensitis, and also thyroiditis, and slight hypertonic, has been slightly hypertonic. Otherwise, no family history, and non-smoker, and B27 negative. At that case, I go back. At that case, and especially because of the peripheral symptoms she had received, from what I could retrieve also from the records, sulfasalazine, we know that it works in some patients, but not in everyone, for peripheral involvement. She was not doing well. She got infliximab plus methotrexate, which I do not prefer, to be honest, because I don't see the reason for giving methotrexate in spondyloarthritis. But in any case, she had a very good response, and she stopped the treatment. She stopped the treatment for about 2 or 3 years. This is one of the very few cases I know for so long being able to stop the treatment. However, she developed inflammatory back pain again with high basti. She had sacroiliitis on the MRI. She tried NSAIDs. She did not work. This did not work. And we had secukinumab at that time. It was introduced in Germany in December 17. So we did what I told you to do. We switched the mode of action. She got secukinumab, it was a good response. However, unfortunately, she lost response to that drug. And now you have, and that's the important thing, now you have someone who has failed the one and has also failed the second, or has not a response, did not have a response or reason to get the same TNF blocker in the beginning, and then she gets an IL-17 inhibitor, so you change the mode of action and you lose response. This can happen in any drug, but this is the case where it developed. And we switched her to ixekizumab. She's doing very well, also with a very low basta. And my takeaway of this is not that the one drug is better than the other, because obviously you will have the patient to treat with the one or the other drug. It is that obviously it makes sense after switching to a one or the other mode of action to then rethink the treatment. And here is a clear example of ixekizumab working after secukinumab. You have seen the other case in the beginning where we had a very clear response to clinics, including improvement of fatigue. And by that, I'm ready. Thank you very much.
Thank you very much, Dr. Baraliakos. Excellent lecture. ¿Alguna pregunta? ¿Alguien quiere hacer alguna pregunta para el doctor? Doctor.
Thank you, doctor. I want to ask, at the beginning of your lecture, I heard you prefer to switch if you fail to a TNF inhibitor to a 17 inhibitor, but in this case, you switch to another 17 inhibitor. So when do you prefer to switch the mode of action, and when to prefer the same mode?
Okay, yes. So that, indeed, this is what I tried to say. In that second patient, she had a TNF blocker and then an IL-17 inhibitor, so we didn't have any other option. So in that case, you do whatever you believe is correct. We switched from the one IL-17 inhibitor to the other, and it worked very well. We have the same experience from switching from the one TNF blocker to the other as well. But the trend goes in the initial failure to switching the mode of action. And if you have two failures like we had it here, then obviously you can decide based on how the patient feels. The reason here was that for safety reasons, and we know that the IL-17 inhibitors have a little bit of a different or better safety profile from what we know from the study data at least, right? The registry data we need to see. We decided for that. We could have decided differently. But I believe that there is lack of experience of switching from IL-17 to IL-17, and this is why I showed this case.
Doctor, thank you very much for your exposition. Sorry for my speaking, but I try to express my question. Well, what is your opinion about the imaging follow-up in patients with diagnostic doubt or with I have a suspect in the diagnostic of SPA, but I don't have complete criteria?
When we treat, so the criteria, I will try to make it very, very provocative. Yeah, forget the criteria. Okay, because if you are convinced that the patient has spondyloarthritis because of the entire picture, then you may not even need an MRI. Yeah, if you have one peripheral joint, let's say hip joint or knee joint or shoulder, the bigger joints are more involved. And you also have B27. And you also have inflammatory back pain in a young person. Then you don't even need an MRI to make the diagnosis. And that's the important thing, to make the diagnosis of spondyloarthritis. Is it axial or is it peripheral? That's a different thing. So I would treat when I am convinced that the patient has a disease. I would not put that patient in a study. It's a different story. So my advice is remember the criteria for understanding the disease, but do not treat the criteria, treat the patient. Yeah.
Hi, thank you for your lecture. My question is, when you have a patient with ankylosing spondylitis treated with anti-TNF inhibitor, and maybe he doesn't respond, and you change him for an IL-17 inhibitor, and it's doing well and the pain is gone and everything, it's okay, but he has suddenly uveitis. What do you do in that case? Because it's frequently, I think, and sometimes it's tricky. Thank you.
That's a very good question, and I can tell you that it reminds me of a patient that I saw last week, and I will now make the parallel, who has been on adalimumab for 7 years, ankylosing spondylitis, and under adalimumab developed psoriasis. What do you do there? It's the same thing, yeah? So I can tell you that we do not have data to show that IL-17 inhibition works in uveitis. If that, as you mentioned, if the patient is doing well, I would treat the uveitis locally. If that does not disappear, I would switch. But I would not switch immediately because the patient otherwise is feeling well. In my patient, in my case that I mentioned before with adalimumab and psoriasis, I did not change the adalimumab either. Yeah? So we try to treat locally the skin lesions, and then we will switch. So my message here is the overall clinical picture is more important than one extra musculoskeletal manifestation, which you can treat locally. If it persists, then I would switch, but not immediately.
Hi. Regarding likelihood radius, do you have a threshold? Oh, sorry.
You need to speak a bit louder because it's relatively loud here in the front.
In regards to likelihood radius, do you have a threshold to rule in a diagnosis? Regarding the likelihood radius, do you have a threshold to rule in a diagnosis of SPA?
You mean if we update the likelihood ratio?
No, no. Do you have a threshold or a number of likelihood radius that you consider to rule in the diagnosis, to confirm the diagnosis, or a level of certainty with a certain number of likelihood radius?
Well, I do not count the likelihood ratios in daily practice. This was just to show you that the clinical symptoms are more important for making the diagnosis if you have more of them. So one MRI positivity is not enough for diagnosis. If you have, or let's put it differently, an MRI positivity is as important as an MRI negative patient with enthesitis and one swollen joint. Yeah? We know that the MRI may fluctuate. If you are negative for your MRI now, 3 months later, every third patient will become positive. But also every third patient will become negative. So MRI inflammation also goes up and down. So the clinics are more important. This is why I brought up the likelihood ratios. I do not count them, I don't calculate them. Yeah? But I take into account how many clinical symptoms does the patient have. I hope I understood the question properly. Okay. Yeah.
Thank you very much, Dr. Baraliakos, for your excellent lecture. But I'm curious about this issue. Although not common, patients with spondyloarthritis can be obese and overweight. Considering the biodisponibility of the biologic therapy, in these patients, for example, the first biologic you consider intravenous or subcutaneous route is only the question.
So the question is, if in an obese patient, the first biologic would be something that you can adjust to the body weight. Well, I don't want to spoil it. I will discuss that later in the session. But in fact, yes, you could do that in an obese patient, but we don't do that actually, because at the moment we do avoid IV implications. So I would rather go the practical way. I would give the injection, whatever that is, and if the patient doesn't respond, then I would go to an IV drug. Yep.
Thank you, Xenofon. You presented nice data about DKK1 and sclerostin. So I would like to know your opinion based on the data about what is the role of this biomarker, diagnosis, prediction, or treatment response. What do you think about that?
Yeah, we do not, I mean, this is just for information. We do not do DKOP1 levels or sclerostin levels in daily practice. Yeah? You don't need to do that. This is all study data, and it shows or it explains why radiographic progression stops. Yeah? By the way, you need to know that CRP and DCOF do not correlate. You may have a patient with high CRP and high DCOF levels, or high CRP and low DCOF levels. But the reason that we believe that biologics stop radiographic progression, especially L17 in that case, is that they have a direct influence on the biomarkers that are associated with newborn formation. And they obviously, you see that the longer you treat, the better the result.
Gracias. Muchas gracias a todos. Fue un placer para nosotros como Grupo Lilly, Laboratorio Lilly Farmacéutica, tenerlos acá, contar con el doctor Xenofon y con todos ustedes. Muchas gracias y que sigan disfrutando el Congreso. Thank you very much. Very nice.
Do you want something? Do you need something?